Gives me tremendous pleasure to restart Medicine Grand Rounds. We obviously went on hiatus in March of last year because of the COVID-19 pandemic, and then took our usual sort of summer break. But I think that overwhelmingly, I heard feedback, and I certainly felt myself that we missed this part of our academic life that really, I think, again, adds some meaning and to being in a center with as many resources, intellectual resources and so on as Emory. So I'm really, really, really happy to resume Grand Rounds. As we thought about how to open this academic year, it was hard to not think about starting off with a COVID-19 related topic, which has touched all of our lives in so many ways, including Zoom and Zoom Grand Rounds, although I think, and I'd love to hear feedback over time, at the end of the day, this may have quite a number of advantages. So I'm very happy to introduce two of my colleagues in infectious disease to talk about COVID-19 and disparities, both as we've seen with the clinical presentations or clinical illness disparities with COVID-19, but also thinking to the future with a focus on vaccine development. And so I think there has been really important work done at Emory in both of these areas. And so we will start out with Zanthia Wiley discussing the first half of that topic, what we know and what we're doing now, and Colleen Kelley picking it up to talk about what's to come and in the vaccine world. Zanthia is an assistant professor of medicine, and her usual day job is as director of antimicrobial stewardship at Emory University Hospital Midtown. Colleen Kelley is associate professor of medicine, and her usual day job is doing research in HIV transmission in particular. Both of them, I think, have had much of their lives upended by COVID-19 and have shifted much of their work also into these topics that you're going to hear about today, really leading efforts in both of these areas. So I'm very delighted to introduce both of them, and Zanthia, I will let you start out.
And so I'd like to share with you all to describe some of the COVID-19 disparities among racial and ethnic minorities, to consider how you can reduce COVID-19 disparities in clinical care and research. So I'd like to introduce you all to Mrs. Jones. So really briefly, she's the first COVID-19 patient that I took care of at Emory Midtown. It was Friday the 13th, Friday, March 13th. I walked onto the floor. She was one of our initial consults. It was really quiet. A lot of people were really anxious. I went in and saw her, and she's a pleasant 77-year-old lady with hypertension and diabetes. Was sitting on the couch. She looked comfortable on 2 liters of nasal cannula. Sitting next to her was her Bible. And in the background, there was CNN on, and it was story after story about COVID and disparities. Socially, she attended church. She was married, had a multi-generational family. So she fortunately did well. However, over time, I've taken care of multiple patients with disparities. And really dedicated to this work. So what do we know about COVID and disparities? I'll go through this really quickly. We all know that there are over 6 million US cases, over 188,000 deaths, and we're one of the 5 states with at least 250,000 cases. We're lucky here at Emory Healthcare to have Dr. Shivani Patel, and she developed a COVID-19 health equity interactive dashboard where you can actually look to see the average daily COVID-19 cases on a county level. And if we look at Georgia, so disregard the little orange county, that's Toomey County that it always defaults to, but look at where we are in our backyard with respect to the high number of cases here in the metro Atlanta area. And if you look at a snapshot of health disparities in Georgia, as you can see, the higher percentage of African American patients that there are higher COVID-19 deaths per 100,000. So not just in Georgia, but also in other counties in the U.S. Other COVID racial data trackers show the same thing, that we're seeing Blacks, Indigenous, the Latinx population affected by COVID. If we look at Georgia, which reports race and ethnicity for 70% of cases and 99% of deaths, Blacks or African American alone account for 31% of the population, 37% of cases, and 43% of deaths. And Hispanic persons, only 9% of the population here in Georgia, but 18% of cases. We see that nationwide, Black people are dying at 2.4 times the rate of white people. And American Indian or Alaska Native and Hispanic or Latino patients are dying at a 1.5 times the rate of our white counterparts. So this is from the CDC.gov, looking at factors that increase community spread and individual risk. So crowded situations, let's think about a small apartment with multi-generational homes, close physical contact, enclosed spaces, duration of exposure. And let's look at the rate ratios of American Indian or Alaska Native, Asian, Black or African American persons, and Hispanic persons compared to white non-Hispanic persons. So with respects to hospitalization, take a look here, 5.3 times higher rate ratios in American Indian persons, 4.7 times the rate of hospitalization in Black or Hispanic persons. And with respects to mortality, our Black patients are 2.1 times higher, have higher rate ratios of death. Let's bring it back home to our backyard right here at Emory Healthcare. So this was published in MMWR from March to April of this year. So in Atlanta, Black patients with COVID-19 were more likely to be hospitalized than white patients. And if you take a look here, 79% of hospitalized patients in this cohort were Black and 45% of non-hospitalized patients were Black. So these were our 6 Emory Healthcare hospitals. And with respects to health equity considerations and racial ethnic minority groups, just take a look at this first sentence here. So long-standing systemic health and social inequalities have put many people from racial and ethnic minority groups at increased risk of getting sick and dying from COVID-19. And I really want to kind of hone in on social determinants of health, which are so important with respects to why a lot of underrepresented minority patients are being disproportionately affected. So let's look at these social determinants of health. And let's think about the neighborhood and built environment. So let's say Mrs. Jones, she lives in a smaller apartment, multi-generational family. You have to consider transportation. How many MARTA bus stops does she have to take to get from her home to the hospital? Health and healthcare. Does she have healthcare insurance? Even if she does have healthcare insurance, let's say Medicaid, does she have the $1, $2, $3 to pay her copays? The social and community context. As I told you, she spends a lot of time at church. I personally go to a church that has 5,000 members. So a lot of people within the same environment. She spent a lot of time at choir practice. So all of these things you have to consider as well. With respects to education, I think it's important. Let's say we're discharging someone with COVID. Can our patient read these discharge instructions? What about their health literacy? And last but definitely not least is economic stability. Does the patient have money to pay for their health care? If they're the breadwinner in a family of 10 family members, they have to go out and drive that MARTA bus. So really considering all of these social determinants of health. So I love this quote by Dr. Mary Bassett, who's a director of the FXB Center at Harvard. So what she says is, try not to focus on comorbidities, that quote unquote, it makes me angry, because it really is about those who still have to leave their home to work, who have to leave a crowded apartment, get on crowded transport, go to a crowded workplace. And we just haven't acknowledged that those of us who have the privilege of working from home aren't facing those same risks. So what are we doing here at Emory Healthcare? And this, I'm sure, is just a few of the things that are going on. So number one, we have to talk about these COVID disparities. The International Antiviral Society, our very own Drs. Armstrong and Dr. Del Rio presented a webinar on COVID-19 meets HIV with a focus on health disparities. Dr. Del Rio also has been publishing on health disparities, looking at the disproportionate impact on racial and ethnic minorities in the U.S. Here at Emory Healthcare, let's just bring it back home. Emory has partnered with the Mexican consulate in Atlanta to address a lot of these disparities in the Latin community. So we have Drs. Guest here, Drs. Rebojedo and Dr. Cantos, who's done a lot of work with testing at the Mexican consulate, also within at Cummings, Georgia, and Warner Robins. And they've done webinars with respects to COVID-19 in the Latin community. So this was about a week and a half ago. So our very own colleagues reaching out and reaching out to the community and educating both us and the community. So we have here at Emory the COVID-19 Collaborative Community Outreach and Health Disparities Research Group, which came out of Dr. Lewin's office. There was a member of the board who essentially asked, what is Emory doing in the community? So Nicole Franks and Ted Johnson are leading this initiative. You'll see multidisciplinary. We have our diversity leads here. Nursing is represented, hospital medicine. And essentially the entire point is expanding relationships with community leaders. So faith-based groups, churches, the Atlanta Medical Association, which is the African American Physician Society here. Other civic organizations. And one project that we're working on is a web-based tool, which is the C19check.com. And it's essentially a web-based tool that a resident or a patient can put in their symptoms, as well as their comorbidities, and it will provide some CDC guidance with respects to where they should go for help. However, what we hope is to use the syndromic surveillance data, link it to public health and demographic data to determine to develop some hotspots. And using a spatial dashboard, not only to inform individual community risk, but also what community resources are present in this hotspot, or in particular, what's not. Is testing available? Is food available? Are there resources for the elderly community? So this is just one of the programs that we're working on. We're also looking at age, comorbid conditions, and racial disparities in COVID-19 outcomes. One of the questions that we had was, what happens? Are the outcomes any different from a patient who makes it to the emergency department? And looking at outcomes of hospitalization, mortality, and acute kidney injury, because there's a lot kind of reported on outcomes in general, but how about patients who actually present to the emergency department? So we looked at 3 months of data, so 831 patients, and divided them into Black and non-Black groups, and also of those who were hospitalized, looked at them with respects to being hospitalized or Black and hospitalized non-Black. And as you'll see here, about 70% of patients, so these were all the 4 legacy Emory Healthcare hospitals. What's a little bit different, actually a good bit different about our data set is, as you'll see, over 90% of patients in both the Black and non-Black group were insured. So this is a highly insured patient population. Comorbidities were definitely higher in Black patients, and more significantly in diabetes, CKD and end-stage renal disease. So what we found is that hospitalization rates were about the same, mortality rate was about the same when they made it to the emergency department, but we found a significant increase in acute kidney injury. So 19% of the Black patients had acute kidney injury, 14% of the non-Black. And when we adjusted it for age, we saw something that was actually surprising, is that the younger Black patients had higher odds of having acute kidney injury. So essentially asking the question, finding the answer. And we know that more research is going to be we're going to have to do more research in these areas, but identifying some of these factors that may be associated with certain outcomes. Also, we're all very proud when we discharge our COVID patients, including myself. However, what happens to them in the crossroads of discharge? So this group, this is the CROSS study looking at COVID-19 characteristics of readmissions and outcomes and social determinants of health. So this is the key here. We're looking at social determinants of health. So as you see here, it's a large group of us. We're representing 5 of the Emory Healthcare hospitals. This is including Emory Decatur. We have Grady representation, VA representation, ID, emergency department, family medicine, Kaiser, etc. We also have a medical student and a resident. So let's look at some of these characteristics. So at Emory Midtown, we have 885 total patients with COVID as of August 14th. 77% were Black, 3.5% Hispanic, with a 3.4% 30-day readmission. At Emory University Hospital, 685 were total, 68% Black, 5.5% Hispanic, and a 1.9% readmission rate. And at Emory St. Joseph's, take a look here, 22% of the patients were Hispanic, with a 2.7% readmission rate. And Emory Johns Creek, the lowest percentage, not surprisingly, of Black COVID patients, and 15% Hispanic, with a higher readmission rate. So looking at what are some of these characteristics. So this is the difference that we just see in 4 of our Emory Healthcare hospitals. How do social determinants of health determine which patients are readmitted? So I look forward to seeing some of the Grady data and the VA data as well. All studies here at Emory Healthcare aren't necessarily targeted towards health disparities. So this is a wonderful study by Sarah Ald and group on ICU and ventilator mortality among critically ill patients with COVID. And she showed that mortality in general had been published as being up to 50%. However, in their study, the mortality was 30%, but I wanted you all to see this because we have 2 fellows who were part of this wonderful publication. Max Edelman was one of the ID fellows, and Alfonso has graduated. He was an ID fellow as well. So really want the students and the residents to know that you can be a part of this. And I bring this up also because whatever work you do, you can actually, it's really important to show a lot of these socio-demographics and report on race and ethnicity. I'm going to go through some of these proposal opportunities and wanted to share also, speaking of fellows and residents publishing, BK is one of our ID fellows who published in Nature a correspondence on deconstructing racism in medicine from training to clinical trials. So BK shared that COVID-19 is more common in African-American patients, and that structural racism in our society really contributes to the significant difference. In the second paragraph, too few people of color are currently enrolled in clinical trials, and she builds a case saying that clinical researchers have an obligation to patients and their families to advocate and educate on the risks and benefits of participation in clinical trials. So our trainees, we want to hear your voice. We need to hear your voice. So put your voice out there. So my last 2 slides, back to Mrs. Jones. So of course, this was not a picture of Mrs. Jones. It was actually a picture of my own grandmother. So COVID and disparities, and all disparities, are personal to me, and I hope that they are personal to you as well. The way that I like to think about taking care of any patient is what I'm offering and suggesting exactly what I would offer to my my mother and grandmother. So I will leave you all with, what will you do? What are you doing, and how can you make a difference?
So we'll go ahead and get started. So my disclosures are listed here, and these are research grants to conduct clinical trials. So in general, vaccines take a really long time to develop, on the order of years. Here you can see this graph for some of the most commonly familiar vaccines to us and how long they have taken to develop since discovery of the pathogen. And we are hopeful that we will have a COVID-19 vaccine in less than 18 months. So this is unprecedented. It has never really been done before. And as many of you are familiar with product development, the reason why things take such a long time is because of the phased implementation or phased discovery and trials of products, including vaccines, that then leads to implementation. So generally there's a lot of preclinical and animal model research, and then you enter phase 1 safety trials, and then phase 2 and 3 in efficacy. And it's not till that's done that the production of a product and a vaccine is undertaken prior to approval. However, things are different now, and that is because of Operation Warp Speed. So you may have heard of Operation Warp Speed. This is an NIH-led initiative partnering with CDC, Department of Defense, BARDA, other HHS organizations in an attempt to deliver 300 million doses of a COVID vaccine by January 1st, 2020. Remains to be seen if we will get there by this deadline, but that was the lofty goal that was set. And in the top, you can see the typical process, 73 months or 6 years to completion for identification of an efficacious vaccine. And that is generally because of the sequential phases, like I showed in the last slide, of vaccine development. However, what's different now is that instead of these steps being taken in sequence, many of these steps are being done in parallel. So none of them are being skipped. No safety checks are being overlooked in the development of a COVID-19 vaccine, but many of the sequential phases are being done in parallel. Most importantly, and most fascinating, is that manufacturing, which is this darker orange bar here at the top, is already underway for the most promising vaccine candidates. So even though we do not have efficacy data yet for the most promising vaccine candidates, those that look to be most likely to be efficacious are already in production. And what has this taken? This has taken a tremendous amount of money. So Operation Warp Speed was appropriated upwards of $10 billion to get to this goal of an effective vaccine by the first part of 2021. And these are ambitious public-private partnerships with the leading vaccine developers and manufacturers. You can see some of them on this slide that were selected from about 14 candidates, and it was narrowed down to about 7 that were thought to be most promising. And these companies have already received significant influx of funds in order to accelerate their clinical trials, but also to ramp up manufacturing of their vaccine. You'll see that the last 3 on the slide, Pfizer, Moderna, and Astrazeneca, have already entered phase 3 efficacy trials here in the US, and the others are anticipated to start very soon. And so this is a pathogen that was just discovered in January of this year, and we are already in efficacy trials with 3 potential candidates. So what did this mean for us in infectious diseases and in clinical trials and academic research? Well, prior to COVID, there were 4 main infectious disease clinical trials networks that were NIH funded. Here at Emory, we had we're leaders in many of these networks: the AIDS Clinical Trials Group, the HIV Prevention Trials Network, the HIV Vaccine Trials Network, and then the Vaccine Treatment and Evaluation units that this year became the IDCRC, Infectious Disease Clinical Research Consortium, that is located here at Emory. all of those NIH-funded clinical trials networks that conduct trials globally, but also here in the US, joined forces to form the CoVPN, or the COVID-19 Prevention Network. And through the CoVPN, clinical trials, multi-site clinical trials in vaccines and monoclonal antibodies are coming. Right now, there's 5 planned efficacy trials that are coming through the CoVPN. The monoclonal antibody studies are really exciting. Those are going to be offered to outpatients as treatment, but also to household contacts for prevention of acquisition and progression of severe disease, and folks that have are household contacts to those that have already acquired COVID-19 disease. There's also some really interesting observational studies so that we can best understand the virus-host interactions of COVID-19 and the human immune system. We will also be undertaking a massive seroprevalence study in Atlanta to understand the penetration of COVID-19 into our local community. And so as of last week, we know that there were well over 100 vaccine clinical trials in phase 1 in preclinical studies. And from there, there's 24 in the phase 1, and there are 9 in phase 3. There's 3 in phase 3 here in the US that I'm aware of. The rest are globally outside of the US. And 3 have been approved for early or limited use. Again, this is outside the US. Many of you may have seen the news from China and Russia that they approved some vaccines for use prior to efficacy data, which we will not do in the United States prior to safety or efficacy data. And so just a little bit of a review of the different types of vaccines that are in use or in development. So we have whole virus vaccines, and those are either killed or live attenuated vaccines. And some examples of those that we use commonly are the MMR, the varicella, the yellow fever vaccine. In addition, then there's subunit vaccines that include protein vaccines, virus-like particles, or toxoid vaccines, and the ones you may be familiar with, hepatitis B, HPV, a VLP vaccine, and then the tetanus toxoid vaccine. And then the last 2 are newer and less well-known vaccine types that are in development. The first is a vector vaccine, which is used a lot in veterinary medicine, but the first human vector vaccine that was approved was the Ebola vaccine as a VSV vector that delivers the genetic material of the pathogen. These can be replicating or non-replicating. They're well known in the HIV field, but the first approved vaccine is the Ebola vaccine. And then finally, nucleic acid vaccines that are very exciting and get a lot of attention. We'll spend a little bit of time on these today. They have both DNA and messenger RNA vaccines. These have never been approved before for human vaccine use, but they are very exciting technology for a lot of reasons. On the right, you can see a publication. All of these vaccine modalities are in development for COVID-19. And you can see the number of vaccines, the protein-based kind of taking the lead, but the viral vector-based vaccines close behind for the number of vaccines that are in development for COVID-19. So lots and lots of folks, lots of labs are working on this, a lot of brain power going into development of COVID-19 vaccines with many different methodologies. And the thought is that we will need multiple vaccine products with potentially multiple mechanisms of action to achieve epidemic control, that a single vaccine will not be successful in achieving pandemic control, maybe because of efficacy, but also likely because of the ability to mass produce the billions of doses that will be needed of a single vaccine. So there are 3 vaccines, as I said, in phase 3 in the US right now, and most of those that are approaching phase 3 are focused on this S protein. This is the surface protein of the COVID-19 viral particle. Its crystal structure was published in Science in March and is pictured here along with the kind of genetic map. This spike protein has 3 receptor binding domains. Generally, only one is visible at any given time, but but this structure allowed scientists to really understand this immunogen as a potential vaccine candidate. As I said, most of the current vaccines that are in efficacy trials are focused on this S protein and producing immune responses to the S protein. So the first vaccine that I'm going to talk about a little bit about is the Moderna mRNA vaccine. This vaccine trial is being conducted here at Emory at 3 sites, as well as nearly 100 sites across the US. The phase 3 trial opened on July 27th, which is really just amazing. So if you look at this timeline, this company had done extensive work on other coronaviruses, MERS included. And then when the COVID-19 pandemic emerged in China, they immediately started developing a vaccine. Soon, the genetic sequence was published on January 10th. Within 3 days, they had a candidate sequence for their vaccine. The vaccine entered phase 1 trials in February. And then phase 3, in March, and then phase 3 in July. And so this is a new technology in vaccine development. It's a very exciting technology, and just to show you a little bit about it. So mRNA, or messenger RNA, is injected intramuscularly into the individual. The messenger RNA is then translated at the ribosome, and a couple of things happened. It produces a viral antigen, and in the case of the current mRNA vaccines, it's the S protein, as I spoke about, for the SARS-CoV-2 virus. That expresses viral antigen on the cell that can then also be presented to MHC1 on the top here, as well as MHC2. To develop not only B cell responses that are incredibly important for antibodies, but also for CD8 responses or cytotoxic T cell responses, and on the bottom, CD4 T cell responses that will be important for antibody development and help. On the next slide, I'm going to show you here the phase 1 results that were published in New England Journal, and Evan Anderson and Nadine Rufael from here at Emory were instrumental in this study and this clinical trial that showed on the left here, or my left here, very good antibody titers to the virus, as well as neutralizing antibody titers. So the difference between the antibody titers and the neutralizing antibody titers at this point in time looks like they are fairly well correlated, but the field thinks that it is the neutralizing titer that will be most important for protection from SARS-CoV-2. On the right, I'm showing you reactogenicity, or symptoms that people experience after they receive the vaccine. And as you all know, symptoms after vaccination can be reported pretty commonly. Things like malaise, fevers, muscle aches and joints, pain at the injection site. You will see that with this Moderna vaccine, the vaccine was very well tolerated. Most of these responses were mild or moderate at most, and they actually occurred in any individual symptom in a minority of folks. You will see, though, that after vaccine number 2, that the responses were more significant, and so we'll be watching for that in clinical trials and safety and efficacy data, whether the reactogenicity or the symptoms that folks experience after getting a vaccine increase with the second dose. When we talk about reactogenicity, it's a little bit of a double-edged sword. We think that there's kind of a sweet spot where some symptomatology should indicate a good immune response to the vaccine, and we anticipate that there will be some symptoms after vaccination. But too much reactogenicity we also think could be a bad thing, in that it actually shuts down the immune response, or the appropriate immune response to the antigen. And so we don't know exactly what the right amount of reactogenicity is, but we think that some level is good and maybe too much is not good. And this becomes important when we turn our sights to the Pfizer mRNA vaccine, which is the second vaccine that's currently in efficacy trials. The Pfizer mRNA vaccine is very similar to the Moderna, although the sequences are obviously different. And there's also some interesting differences in storage of this vaccine. This vaccine will require storage at -70 degrees, which is not something commonly found in a clinic or a public health facility for vaccine storage, so it's something to keep in mind. But Pfizer had 2 mRNA vaccine candidates. And here we're showing comparison between B1 and B2, which is the second candidate. And they were also able to compare their vaccine responses and reactogenicity between younger and older adults. Clearly, older folks have much more severe outcomes with SARS-CoV-2, and we particularly want a vaccine that is going to work for elderly folks. And we can see that there was less reactogenicity with the B2 Pfizer vaccine. This was in the setting of having very similar binding and neutralizing antibody titers that are shown here on the right side of the slide in panels A and B. All of these vaccine candidates that I'm showing you are going to be compared to human convalescent serum. So people who have recovered from SARS-CoV-2. And so we don't know exactly what the best correlate of protection is to use in these vaccine trials, but in general, most are using human convalescent serum to compare their titers of binding and neutralizing antibodies to. And so Pfizer elected to go forward with this B2 mRNA vaccine into their efficacy trials because it had similar immune responses, but less reactogenicity in older adults who we very much want to protect. The Astrazeneca vaccine is actually one of those viral vector vaccines. It's a chimpanzee adenovirus vector vaccine that delivers the genetic code for the spike protein on the SARS-CoV virus. This vaccine is interesting and the only vector vaccine in phase 3 clinical trials at this point in time. It also shows good antibody as well as neutralizing antibody responses as compared again to convalescent plasma specimens here on the far right of this panel. It also shows reactogenicity, as all vaccines do, and this one also appears to be greater after the second dose of the vaccine, similar to the Moderna vaccine. But again, we're talking about chills, fatigue, fever, muscle aches, headaches, and in general, very mild experience of these symptoms, and not something that should be limiting to delivery of the vaccine. Finally, the last one I want to tell you about is not yet in phase 3 clinical trials, but we do anticipate that it will be starting next month, or actually likely at the end of this month or early next month in October. This is a Novavax product. It's different than the mRNA and the vector chimpanzee adenovirus vector vaccines, and that it's a recombinant protein plus an adjuvant. And what's interesting about this vaccine is that the titers of binding antibodies as well as neutralizing antibodies are very high, and actually higher than what we're seeing for the most part in convalescent serum. And so folks are very interested in these high neutralizing antibody titers, if we will see better outcomes with this vaccine compared to others. We really don't know yet. Again, very similar safety profile to the other vaccines with respect to the symptoms that folks experience after they get a COVID-19 vaccine. I don't think there's a lot of difference between these vaccines as far as side effects, and that some level of side effects are anticipated with any vaccine, and especially the COVID-19 vaccines. So we're asked all the time, which of these candidates is the best? Which trial should I try and participate in? Which vaccine should I hold out to get? And we just really don't know. And the reality is that we're going to need multiple vaccine candidates that are efficacious in order to end the pandemic. All of the vaccine candidates currently in phase 3 trials show good neutralizing titers. What we don't know is how high is high enough. Will it be enough to prevent acquisition of disease, or will it only be enough to prevent severity of disease or progression of disease to symptomatology or severe outcomes such as hospitalization or death? We don't know that yet. With good neutralizing titers, we hope that there's less risk of something called antibody-dependent enhancement or vaccine-associated enhanced respiratory diseases. These are both things that have been seen with other vaccination for respiratory viruses as well as dengue with different immune responses. And so that is something that is being watched for very carefully. There's not been anything seen in animal models or to suggest in vitro for the vaccine response that these things will be a factor, but it is something that they're watching for. Most of the vaccines in phase 3 and those that are close to phase 3 have good T cell responses that are skewed to the Th1 subtype. This is thought to be a good thing because we think that there may be some protection in the absence of adequate antibody responses if we can also get T cell responses. And we think that this will lead to less risk of vaccine-associated enhanced respiratory disease as well. All of the vaccines currently in phase 3 require 2 doses. There is a vaccine in development, the Janssen vaccine from Johnson & Johnson, that could end up being 1 dose. But that has not entered phase 3 clinical trials yet, but is anticipated to come soon. So 2 doses, obviously, implementation will be more difficult than 1 dose, and so we'll have to see how that goes. All of these vaccines, as I've been saying, have a reasonable side effect profile so far, but any vaccination can result in some mild side effects, and that's to be anticipated. And the most common ones are pain at the injection site, fever, malaise, muscle aches, and headache. We absolutely do not know how long immunity will last. Will this be something that will last lifelong? It's unlikely. Or is this something where revaccination will be necessary, and how frequently will it be needed? We don't know yet. And then finally, as I mentioned before, we're very interested in understanding how these vaccines are going to perform in older adults, because clearly the morbidity and mortality has been a great burden to folks who are older. So recently in the news, a lot of press was out. Dr. Fauci says there is a legitimate way to end coronavirus vaccine trials early. So why is that? And essentially it is because of the sheer size of these vaccine trials. The current trials in the current candidates in efficacy trials are enrolling upwards of 30,000 people into their clinical trials. And so the number of events that it will be necessary to see efficacy depends on the actual efficacy of vaccine, but the number of events could be somewhere as low as 50 to a high as a couple of hundred of COVID-19 events or acquisitions, which is what we're looking for, to determine whether the vaccine is efficacious or not. And depending on what the incidence of COVID-19 is in the communities where these vaccine trials are occurring, it is conceivable that we could reach the number of endpoints or the COVID-19 acquisitions that are needed soon, potentially in the next few months. What we'll also need to ensure, though, is that we have enough safety data as well to understand what the side effects and the risks of are these vaccines before they reach approval. And I think we have commitment from the scientific community as well as the companies that are producing these vaccines that there will be no approval of vaccine prior to knowing whether it is efficacious and safe in the United States. I think this is something that people have been quite worried about, but I think that we have consensus and commitment to that from, as I said, the scientific community and the companies that are producing the vaccines. So just to get back a little bit to the title and then to hand it back over to Zanthia, when we're talking about disparities in COVID-19, you may have heard some news that researchers are striving hard, or we're really trying to recruit underrepresented minorities into these COVID-19 vaccine trials. And why is this? It's really important that trial participants represent the US population. And some have offered that a vaccine could perform differently among underrepresented minorities. We're going to talk a little bit more about this on the next slide because I don't think people are thinking about this in the right way, but we'll talk a bit more about that. Also, it's really important that those who will benefit most from an effective vaccine should be overrepresented in the clinical trials. So those folks who have been most hardest hit by COVID-19 morbidity and mortality, including underrepresented minorities, the elderly, and folks with pre-existing conditions, those folks need to have access to participation in these clinical trials. And this is really how we build trust in the results. This is how we know at the end of the day that this vaccine will work and will be efficacious and will be safe if the composition of our clinical trials is made up of those folks who are most likely to benefit. So when we talk about why a vaccine might perform differently among underrepresented minority groups, really this gets back to structural racism. And in 2010, we've been learning a lot about how structural racism results in adverse health outcomes. On this slide, I've just represented a few of the factors. There are many, many more that we could include, including segregation and poverty and access to healthcare, that as a group, results in adverse health outcomes for Black, Latinx, as well as Native American populations. Vaccine efficacy is one of these adverse health outcomes that we could see differences. If as a group, these folks experience these factors differently, that vaccine efficacy will also be affected for different underrepresented minority groups. And that is something that is very important to remember. So as I stated before, Emory, we are participating in these clinical trials. Currently, the Moderna mRNA vaccine is open at 3 sites at Emory, at the Hope Clinic in Decatur, at Emory Children's Center on main campus, and then at Grady at the Steiner Building in the Ponce Clinical Research Site. As I stated before, this vaccine has an excellent immune response and a good safety profile. It is 2 shots that are spaced 1 month apart. And then after folks get the vaccine, they go into 2 years of follow-up with COVID testing as needed if they develop any symptoms that could be consistent with COVID. Our priority populations for this trial, which will be the same for the future trials, include the elderly or those folks over age 65, essential workers that are unable to socially isolate, so not just our healthcare workers, but grocery store workers and factory workers, transportation workers, et cetera. Folks with comorbidities that put them at increased risk for severe disease, as well as underrepresented minorities that we spoke about. So we're very interested in those folks enrolling in the trial. So if you are interested yourself or you know someone who might be a good candidate, you can send them to this website here, the coronaviruspreventionnetwork.org. They can input one of our site codes and we will get their information directly to potentially enroll them in the clinical trial. The Moderna vaccine trial is anticipated to be open for a few more weeks, but there will be subsequent products that I spoke about earlier in the presentation that folks can might be eligible for after this one. So finally, this is that website where people can go to learn more about COVID-19 vaccines and how they can participate. So finally, I'll just wrap it up very quickly. Just only a vaccine will end this pandemic. We anticipate that 60 to 70% of population immunity is needed to end the pandemic, and that will not be achievable without a vaccine and likely several effective vaccine candidates. There's absolutely reason to be hopeful. I hope that I've conveyed that today. We have several promising candidates that are in phase 3 efficacy trials that we hope to have signal for in the next few months, and so we are very hopeful. But our job is to ensure that those who will benefit most, again, underrepresented minority groups, the elderly, have access to a safe and effective vaccine first. And I think a lot of planning, a lot of thought is going into this as we speak. So I will stop there and thanks the folks on this slide as well as our research groups and research support.
Colleen, one of the questions that came across in the chat was, can you explain a little bit what antibody-dependent enhancement is and why that's a concern?
Yes. So this is something that's been seen with dengue vaccination. And basically what it is when neutralizing titers to the virus are not quite high enough, it can result in binding of when a subsequent infection occurs. And with dengue virus, that's with a different subtype. Can incur a production of other antibodies that then can result in complement fixation and illness that is more severe than what might be expected at baseline. And so it's it's been a very unique thing seen with dengue virus vaccination, where the antibodies that were induced by those vaccines were actually dangerous if someone acquired a different dengue virus subtype. But it is something that it could be potentially seen, although thought to be unlikely, with COVID-19 vaccines. Hopefully that was a good answer to that question.
Hi, I have a question.
Dr. Manning.
I think I might have not heard all the details on it, but I had a question about the part where you mentioned a vaccine associated like respiratory response or something like that after someone has received a vaccine. I'm just thinking, just would love to hear a little bit more about that, and if that's something that is common. Is it something that we see with influenza vaccine? And forgive me if I have the term wrong.
No, it's vaccine-associated enhanced respiratory disease, and this was something I knew almost nothing about before COVID-19 vaccines. It is something that's been seen with other respiratory viral candidates like RSV vaccine. It's not something that's been seen with influenza or other approved vaccines. It's something that is discussed a lot in the pediatric literature, again, around RSV vaccines, and it tends to occur, we think, again, when you have not adequate levels of neutralizing antibodies, or if you have a T cell response that's skewed to the Th2 phenotype, and results in actually accumulation of immune cell subsets, I believe, in the lungs to result in enhanced respiratory disease in the setting of vaccination. So again, it's not something that's thought to occur, that will occur with COVID-19 vaccination, but it is something that folks have at least considered and are thinking about in the immune responses that are being described with these COVID-19 vaccines.
On that, Dr. Taylor asked, is the Moderna trial slowing the increase enrollment of URM participants, and are we close to targets for URM in older participants?
So I think that they're doing a much better job of enrollment of underrepresented minority groups as well as older participants. I'm not at liberty to discuss the exact numbers, but I think that, as I said, they are doing much better. And yes, they did slow down just a bit to ensure that those folks were getting the opportunity to enroll in the trial. And so I think things are on a much better path than when the trial first opened overall. So does prior recent adenovirus exposure make vaccine less effective? That is a fantastic question. So there are a lot of different adenoviral vectors that are being considered in vaccine development. There are human adenovirus vectors, and in that case, yes, we do think that prior exposure to adenoviruses, which are pretty common respiratory viruses, can affect vaccine response. The current adenovirus vector vaccine that's in phase 3 clinical trials is actually a chimpanzee adenovirus as the backbone, and we think that there will not be much cross-reactivity based on prior exposure to the chimpanzee adenoviruses, and so it makes it a better vector potentially than the human adenoviruses. It seems that protein replication takes place in the deltoid area where other sites and methods of administration be examined. For mRNA vaccines, I am not aware of other sites of administration. There may be, but I'm not aware of that. Is there a maximum age for the vaccine trials? I don't know the inclusion-exclusion criteria for every single one, but in general, no, there's not a maximum age if you are able to come in to the clinic and get your vaccine.
And there's one that's further up, Colleen. Are there safety or efficacy concerns with the novel mechanisms like vector-based or mRNA vaccines?
Again, the vector-based and mRNA vaccines are new to the field. And so, yes, of course, we want to know more about safety and efficacy of these because we don't know as much about them. They're not in use for other pathogens with the exception of the Ebola vector-based vaccine. And so we're watching for these things, and that's why we're doing the trials. At this point in time, we don't have significant concerns above the other types of vaccines, but there may be things we don't know yet. And so we're watching out for that. Will declines in community spread of COVID result in any delays in safety evaluation? So yes, the decline, the incidence of COVID-19 is declining, thank goodness, in Georgia and in the Atlanta area, as well as many other places in the US, although not all places. Had we conducted our trial in Athens a couple of weeks ago, we may already have efficacy results. So yes, the incidence of COVID-19 definitely could result in delays in efficacy or safety evaluation. We will just have to see how that goes. But I think we all think that declines in incidence are overall a good thing.
And so thank you so much, Zanthia and Colleen, Dr. Wiley and Kelley, for really outstanding presentations to kick us off this year.